Thank you so much for that introduction. Thank you, Peter, for inviting me, and I'm very happy to be here at the Leuven Center for Health Humanities. So today in this talk, I will first outline the current need for and potential uses of artificial intelligence and machine learning technologies in mental health care. Some of the technologies I mentioned are appropriate in psychiatric care, where the emphasis is much more on medication, and others are also appropriate in psychotherapy, where drugs play less of a role. I then present the position that trust is the moral foundation of medical practice, specifically a doctor's obligation to seek trust and to be trustworthy is the moral foundation of the doctor-patient relationship. And this is a view that I take from bioethicist Rosamund Rhodes. Further, I argue that there are special challenges for trust in the context of the provision of mental health care, and that these can be exacerbated by the use of AI and ML technologies. I discuss 5 different ways in which the trusting relationship needed for care could either be undermined or complicated by AI, including the promise of empowerment, epistemic injustice, medicalization, respect for autonomy, and confidentiality. I thought I should start out with some statistics. Since I'm from a technical university, no one takes you seriously unless you have some statistics in your talk. So maybe these are statistics you're already vaguely familiar with, but approximately 1 billion people suffer from mental health disorders globally. That's on a recent estimate by the WHO. Mental and substance use disorders are now the leading cause of disability worldwide. And this problem is not evenly distributed. 75% of this global burden of mental health diseases is found in low and middle income countries. The COVID pandemic greatly exacerbated mental health conditions. The need for care has grown globally, and it's hit young people especially hard. So there's been an increase in mood disorders among young people during and after the COVID years. Women were also more affected by men by major depressive disorder and anxiety disorders. Now, as you know, I live in the Netherlands, which is a high-income country, but we still face very long waiting lists for mental health care. At the end of 2022, 84,000 people were on a waiting list for mental health care in the Netherlands, and 51% of them were waiting longer than the maximum of 14 weeks that it is deemed acceptable to wait for mental health care. And this means that the care for these individuals falls to GPs who often lack the training and the time to provide these patients with what they need. And the people who suffer the most in the Netherlands, at least, and I assume this is probably the case in other places in Europe as well, are patients with complex or serious problems, often people who have more than one diagnosis. For example, a mood disorder and a substance use disorder. So this is about 11,000 people per year have to wait around 4 months or longer before their treatment can begin. So I've heard, this is anecdotally, but of many people waiting for at least a year to have access to a specialized mental health care provider. And the government has done some analysis of this and tried to find out why this is happening. Of course, there's simply a shortage of staff. This is one of the main reasons. But there are also some financial incentives in the system to treat the kind of easier cases first and to clear them out of the way. And if people require inpatient care, there's also a shortage of beds in inpatient facilities. So as I said, the World Health Organization has described this as a global mental health crisis. And as in the case for many complex and widespread health problems, governments, corporations, researchers are seeking techno-digital solutions to this crisis and hoping, especially now, to harness the growing power of AI, emerging AI and machine learning tools to solve these problems. The promise is that mental health care can be supplemented, in some cases replaced by technology that can offer a variety of benefits. For example, benefits in delivering care or diagnosis efficiently. So it can be done without the long waiting times. It can be done in a way that prevents risks and thus actually decreases the need for mental health care overall. Presumably, it can also be delivered in a way that's cheaper and hopefully also better. So advantages of using AI and ML technologies in mental health care are things like the promise of personalized medicine, the possibility of offering care in a variety of different languages, so it's appropriate for individuals, offering care, treatment solutions that are more discreet or maybe more accessible to people who would be unwilling to seek out care from a medical professional. They also offer the promise of providing care that's better in the sense that it offers objective data or measurements to inform psychiatric practice and psychological practice, in addition to the subjective reports of patients on their own symptoms and inner states. It may also be available to remote or isolated communities, although those are pretty hard to find in the Netherlands. So, although a wide range of digital solutions are being developed to close this capacity gap in mental health care, here I focus, as I said, on those that use some form of AI or machine learning, but I'm not a computer scientist. I don't do AI, so I'm using these terms as a relative lay person. These are just some very simple definitions of the terms: artificial intelligence, which encompasses machine learning and deep learning. I'm using AI here to mean any technique that enables computers to mimic human intelligence using a variety of methods. Could be decision trees, it could be machine learning, it could be deep learning. Machine learning offers experts or allows experts to train a machine by making it analyze massive data sets. Of course, the more data the machine gets and analyzes, the more accurate its results can be. And it's able to make predictions for unforeseen events and scenarios. Some of the most commonly used types of AI in medicine more broadly right now are in the fields of diagnostic imaging. So it's quite widespread in serving as a tool that reads scans in radiology, for example, often doing a better job or at least a comparable job to an expertly trained radiologist, often detecting abnormalities or changes to tissue that are undetectable by the human eye. AI is also being pretty widely used as a decision support tool for physicians, helping them make decisions about possible courses of treatment and the percentage, like the success rates of possible different interventions, given a wide variety of data. And most recently, ChatGPT is being experimented with to do patient intake, so to just gather information from patients about their condition and even to triage them to decide who is an urgent case and whose care can wait. The use of AI in mental health care is really in its infancy compared to all of the other areas of medicine. So most of the studies that I have in my long reference list in the end, or the cases that I mention, are really small scale. But the areas of application are roughly the same as in other areas of medicine. AI is used in diagnosis, prediction and screening, treatment, and as a decision support tool for professionals. This diagram illustrates some of the envisioned and current research applications of AI in psychiatry specifically. So you can see in the middle here, lots of different sources that could potentially be mined to train artificial intelligence or machine learning algorithms. Things that range from brain scans to speech recognition to gene sequencing to wearable devices that collect data from us on an everyday basis. Some examples of the use of AI in prediction and screening in psychiatry, just to give you a flavor for what I'm talking about here. involve things like detecting early signs of relapse in mood disorders, specifically in bipolar disorder. And this seems to be able to be done using wide variety of data sets, things like phone use, monitoring of head movements, facial and vocal characteristics, logs of SMS or text messages, including the content of those messages. In some studies, skin temperature, electrodermal activity, light exposure, and physical activity. And I could go on. There's also research on suicide prediction based on data from the electronic health records, or patterns of social media use, including content posted. Probably many of you are familiar with projects that Facebook tried to do a few years ago using the content and frequency of posts to make suicide predictions. And prediction of panic attacks using biosensors. There's also work on dementia using predicting very, very early onset dementia with brain imaging or data from speech processing. This is just an example of one of the wearables for panic attacks. It's called the BioBeat 7, and it collects all kinds of information about the user and has periodic check-ins with the user on their mood and tries to give them a warning in advance of a panic attack because their justification is that much of the terror of panic attacks is anticipating the next panic attack and not knowing when it will hit, I'm sorry. There's research now at Vanderbilt University Medical Center looking at hospital admission data and demographic data and using machine learning to predict suicidality in patients that were once admitted to the hospital for suicidal ideation. At the Alan Turing Institute, AI is being researched to use when a patient is likely to slip into what they call medication noncompliance or non-adherence, and issue reminders or alerts to that person to try to help them get back on track, or even notify their healthcare provider to nudge them to start taking their medication again or to find out what's triggering their noncompliance. There are also examples from diagnosis. So researchers are looking to discover biomarkers for mental illnesses, for example, schizophrenia, not necessarily a mental illness, but ADHD as well, using brain imaging or vocal traits. And as I said, creating decision support tools, which can determine which patients are likely to benefit from certain types of therapy, like CBT or certain types of medications, rather than experimenting for potentially years to find out what works. And then finally, there are examples from treatment. So the most common treatment example is treatment with an AI or ML-powered chatbot for mood disorders, depression, and anxiety. But there's also research on finding new targets for drugs and greater precision medicine, as well as engagement, adherence, maintenance, and monitoring of medication or recommended exercises and lifestyle changes. Here we have two of the most popular and most evidence-based AI-based chatbots for mental health. That's Woebot and Youper. I don't know if any of you have seen these before or tried them out. Woebot uses natural language processing and cognitive behavioral therapy. You can see here in the chat that it claims to offer empathy to the people who engage with it and actionable tools to work on people's problems. Youper primarily uses something called just-in-time interventions delivered in the moment of need when a person is feeling low or anxious to help users practice and learn skills for emotional regulation. Okay, so now that I've given you background on the AI in psychiatry and psychology, I'm moving on to the medical ethics framework that underlies how I think about the introduction of these technologies. And that's the idea from Rosamund Rhodes' work that medicine has a distinct set of moral responsibilities that sets it apart from the obligations we have as everyday folks and also from other professions. This is in contrast to some other very prominent medical ethicists' views, like the views of Bishop and Childress or Gert Culver, who argue that the ethics of medicine closely resembles the ethics of everyday life. It's just a slightly specialized case of everyday common morality. Rhodes gives several persuasive examples to illustrate this difference. For example, a doctor, a regular person may be free to allocate their time and interest and kindness to whoever they choose, their inner circle of intimate loved ones. But a doctor is not free to do so in the course of their practice. They need to treat people based on considerations that have nothing to do with personal preferences, whether the person is attractive or pleasant, or smells good or smells bad. Medical need and urgency are the things that matter. Similarly, as a private citizen, I'm free to share the juicy gossip that I hear about my coworkers around the water cooler. Maybe it's not the kindest thing to do, but it's not maybe a serious moral wrong. Whereas for medical professionals, confidentiality is at one of the top of the list of moral obligations. They're only allowed to share information on the basis that it would help improve the care of a patient. So this view emphasizes the fiduciary relationship the doctors have to their patients, right? The general public agrees to the medical profession having all kinds of special rights, like to cut people's bodies, to give them drugs, right? To decide who gets to have access to drugs, to quarantine people sometimes in order to prevent the spread of infectious disease, to decide that someone lacks decisional capacity, and in that case, maybe even impose treatment on someone against their will or over their objection, and even to determine when someone has died or when someone is still alive. So these are powers that we grant to the medical profession and we grant to doctors on the condition that doctors seek our trust and be trustworthy. In other words, the physician-patient relationship contains inherent inequalities of knowledge, skills, control of resources and powers, and it also deals with matters of the greatest importance to people. And this is why physicians are held to such high ethical standards, and we can expect them to be obligated to act in accordance with a wide range of moral and professional commitments. And I don't think that I need to read all of these to you because you're probably familiar with them, but a long list of the many moral commitments that we count on our doctors to honor. So as I've said, doctors take on these responsibilities by creating expectations in patients and in society. The expectation that they have expertise, goodwill, and professionalism. I've been using the word trust a lot, and I know trust is one of the themes of this series of lectures. So I'd like to just offer my favorite definition of trust, which comes from a colleague, Philip Nickel. Here he defines it as an attitude of willingness to rely on another person to perform actions that benefit or protect oneself or one's interests in a given sphere of activity, together with a normative expectation the person or entity should perform in a particular way. So what I like about this definition of trust is that it distinguishes it from mere expectations that a person or institution will act in a certain way. It's an explicitly normative, morally laden concept. If I trust someone, I count on them to act for my good, not just I count on them to act in the way they've consistently acted in the past. Of course, the extent to which individuals trust doctors can be mediated by a variety of factors. It shouldn't be taken for granted that everyone trusts the medical profession. It can be mediated by an individual's past experience with medicine, but also, especially for disadvantaged groups, the way that they've been treated as a group as a whole by institutions of medicine. So race, ethnicity, and socioeconomic impact. Trust to a great extent. as do specific characteristics of the physician or the institution that they're embedded in. For example, if people have the perception that their provider is closely aligned with the pharmaceutical industry, this could undermine their trust. And then finally, an emerging area of research, and I heard you're going to have a talk about this in a few weeks, which I'll try to attend online, is the use of technology in the context, right? So how technology also changes the extent to which people trust their physician. And what I've started thinking about is how AI, and especially the way in which physicians communicate about technologies like AI and machine learning can impact trust. I've spoken about trust in medicine in general, but this talk is supposed to be about psychiatry. So psychiatry, and to a large extent, clinical psychology, faces some distinct ethical challenges, and these providers have some distinct ethical obligations. These are just some of them. They have to be careful about crossing boundaries with their patients in an intimate setting. They have to deal with the very large power imbalance that exists and the unique vulnerability of their patients who may have cognitive difficulties or have trouble distinguishing reality. They also are obligated to work towards reducing the burden of the stigmatization of psychiatric illness in society and respond to the many critiques of the field that have been around since the 70s, but are taking on more and more momentum now. So critiques of the DSM, for example, the neurodiversity movement, the MAD studies movement, and recent scientific critiques of some of the foundations of the practice of modern psychiatry, say the chemical imbalance hypothesis about mood disorders. To go on, they also have to deal with the fact that it's uniquely important in their relationship that they cultivate their soft skills, their empathy, and the therapeutic alliance. They have a special power and a duty to involuntarily commit patients to care, and also the possibility of having to invoke a duty to warn or a duty to protect, which means that they might have to actually engage with law enforcement or the state if there's a potential that one of their patients could be a serious threat to someone else. In the United States, this is based on a case law called the Tarasoff ruling. There's no really explicit corollary to that in Europe, but there are some norms about warning possibly seriously endangered third parties. And then final challenge is that they have to a large extent rely on the subjective reports of their patients, of course, and their clinical observations instead of extensive biomarkers, blood tests, or imaging. So I claim that these features of psychiatry make it at the same time more important for psychiatrists to be trustworthy and more challenging to achieve this trust. So now AI and machine learning technologies enter the field, and I think that they further complicate things. The examples that I'm going to give don't lead me to conclude that AI and ML should stay out of the field of psychiatry by any means, but rather that we have many complex ethical puzzles to sort out, maybe before we fully deploy these technologies. So let's start with the most widely used AI for mental health. And as I mentioned, those are chatbots, right? So companies like Uber advertise themselves as artificial intelligence to solve the mental health crisis. Chatbot companies and the institutions promoting them, including governments and ministries of health, often tout the powers of these technologies or the ability of these technologies to empower patients who are struggling with their mental health. And they frame empowerment as an inherently valuable goal. This is something that I've recently done a little bit of research on with two colleagues at TUE. It seems that they often fail to offer true empowerment on the one hand, for a variety of reasons, and I'll mention some of those. And they also overlook the fact that empowerment might not really be what people are looking for when they're seeking mental health care. The kind of empowerment that these apps offer is often based on unjustified assumptions about who their patients or users are and what capacities they have. So what we see happen with these technologies is that the people who tend to get the most benefit from them are people who are already extremely motivated and active in terms of promoting their own mental and often physical health as well. They're not the people whose care is falling through the cracks. So in order to achieve this empowerment effect, this kind of higher level of control and self-management of one's mental health, we have to assume a high level of technological literacy and of technological access, as well as a high level of motivation to engage continuously with the technology, and high levels of social, cognitive, and attentional resources that not everyone has. And this might be an especially acute mismatch when it comes to providing tools to people who are struggling with mental health issues. Secondly, as I said, empowerment can actually entail an unjustified shift of labor and responsibility onto the individual for related health outcomes. So a kind of responsibilization of one's mental health, moving it from the providers to the patients. This is unjustified because it sometimes or oftentimes involves neglect of the macro forces and social determinants of health that are contributing to users' struggles in the first place. And this can also lead to users experiencing being left alone or abandoned to the care of the app, and even risk feeling blamed if they fail to use the digital tools that they have available to them. If this message of empowerment is one that is endorsed by one's doctor or mental health provider, it undermines the trust that the patient has in their doctor's competence to recommend solutions that work for them, and their commitment to providing them care and to telling them the truth. My second example has to do with epistemic injustice. So imagine a patient with a diagnosis of bipolar disorder whose doctor is using a variety of AI-powered tools to predict a relapse into a manic state. In a meeting with her doctor, the patient might insist that she is just genuinely excited about a new project at work and she doesn't feel like a manic state is imminent. Whereas her doctor may favor the seemingly more objective prediction by the algorithm that suggests that she's at high risk of a relapse. Her own experience with her condition might be dismissed unjustly, causing a breach in her trust, causing her to doubt that the doctor takes her seriously and respects her autonomy. We can understand this as a case of something called epistemic injustice, a term coined by Miranda Fricker. Epistemic injustice is a kind of unfairness done to someone in their capacity as a person who can know things, and really their ability to be seen as by others as a person who knows things. In general, in testimonial injustice, that's a specific type of epistemic injustice, people discount the credibility of what others say because of some kind of prejudice against their social group, perhaps because they have a mental illness, or perhaps because they're a woman and they're claiming that they were sexually assaulted, or because they're part of a certain ethnic group. McCradden and Buchman have pointed out that epistemic injustices can be created in treatment and diagnosis using AI and ML if, quote, the algorithmic information is considered a superior way of knowing and the patient's subjective self-report is treated as ranked lower as evidence in clinical decision-making. Epistemic injustices can be made even worse if they are based on problematically biased data sets. So if the AI or machine learning is trained on problematically biased data sets, then epistemic injustice is compounded. Of course, doctors themselves can be biased, and there's lots of research on the ways in which they are biased. And in medical education, oftentimes physicians in training are taught to work on combating those biases. For example, we have a great deal of evidence that women are overdiagnosed with borderline personality disorder. However, In the case of physicians overcoming their individual biases, they can work to become aware of them. It's possible, or at least take measures to try to counteract them. But if the biases are built into the tools that one's using, this becomes much more difficult. Bias, or the perception of bias, undermines trust in the doctor-patient relationship. Third, medicalization and self-insight. Recently, Minerva and Giuliani have argued that people lack a self-awareness about their mental health problems. And this is one of the advantages that AI has as a tool in psychiatry over traditional psychiatric methods like a clinical interview. Specifically, they point out that many people do not attribute their symptoms to mental illnesses, but rather to just kind of the routine difficulties of life, fatigue, age, or life stressors in general. They point out that AI could use widespread digital monitoring to screen for mental health problems in people who are otherwise considered healthy or consider themselves healthy or normal. And this could raise awareness and allow these people to seek treatment and to potentially benefit. But they do acknowledge that this type of widespread screening could lead to medicalization, potentially over medicalization. Medicalization is the process by which non-medical, cultural differences, or just human problems become understood as and treated as medical problems. And of course, there are good, bad, and controversial forms of medicalization. A recent one comes from the DSM-5, that's prolonged grief disorder. Basically being sad about someone's loss for too long or in a certain kind of way, after a while becomes a disease. We can imagine a patient who goes to see his GP for his high cholesterol levels. He sees himself, as all the men in his family do, as being a bit moody and melancholic. He's lonely after his wife died a few years ago, and his grown children have moved far away. He sees seeking psychological or psychiatric help as only necessary for those who cannot function in their daily lives. His GP suggests he uses his electronic health record to do a routine mental health screening powered by AI, and it suggests he's a good candidate for a referral to a psychiatrist to be assessed for depression. Now, if AI screening tools become widespread, many more people may come to see themselves as mentally ill when they did not before. It's an open question whether this is a good thing or a bad thing, whether this is a moral problem or not. But it will likely be mediated by the ways in which people trust or distrust the medical professionals deploying these tools. This trust may also be mediated by the extent to which these models and tools are transparent and explainable. I should have clicked the slide earlier, sorry. They also may be mediated by the extent to which these tools are explainable to patients. So the extent to which the psychiatrist or psychologist can say, here's how I came to the conclusion that you need this referral, right? Now, if he was doing that through his own reasoning, he could explain it quite easily. But if he's using something like a machine learning algorithm that he doesn't understand, and perhaps even the developers of which don't fully understand, that explanation is going to be a lot more tricky. Finally, respect for autonomy and confidentiality, the classics. So, of course, as we all agree, it's of paramount importance in psychiatry and psychotherapy, confidentiality. There would be no way in which patients would reveal their innermost thoughts and fears and obsessions without this trust that their confidentiality will be guarded. And of course, there are limitations, right? As I mentioned earlier, there are these unique powers in psychiatric medicine. It's possible to involuntarily commit patients to care when they lack the decisional capacity to commit themselves, or when they pose a serious a threat of harm to themselves or others. These are cases where a psychiatrist or psychotherapist might be justified morally in breaching confidentiality and failing to respect autonomy to prioritize other moral obligations they have, such as beneficence. The introduction of predictive and screening AI and ML tools may create a new scope of obligations for psychiatrists to act on new streams and sources of information, or to use these tools extensively once they become available in making further assessments. So, as with many medical technologies, oftentimes a technological imperative starts to slip in. Once the tool is available, it tends to be used. The technology is available. And once the technology is available, it's a moral choice that has to be made, whether the doctor will use it or not. The accuracy of these tools may provide potential justification for even demanding access to certain kinds of personal data from people, especially for particular populations. Smartphone data, for example. Patients in ongoing psychiatric care might be required to submit to certain kinds of everyday routine screenings to mitigate risks of relapse. Oops, that's my timer. To mitigate risks of relapse, suicide attempts, etc. We might pick out particular vulnerable groups like young women using Instagram who we know are at high risk of eating disorders, or members of the military who are at risk of developing PTSD. And if they do seek out care, they may be asked to submit their data for certain kinds of monitoring for their own safety, potentially for the safety of others as well. Some final thoughts. Some bioethicists argue that we have a moral obligation to participate in medical research. I agree with them. This is justified by an obligation to avoid free riding on other people's contributions to medical science. And it's also related to concerns about distributive justice, as well as a general duty of beneficence towards our fellow human beings. I'm thinking about this question: is there an analogous yet defeasible moral obligation to share our data, psychiatric and psychological, to train AL and machine learning models in order to be more accurate and effective in diagnosis, prediction, and treatment? Such an obligation may exist, but it can be defeated under certain conditions. Maybe if there is insufficient trust in the various institutions or individuals that are doing the research, translating it into medical applications, and deploying the technology. Or if there are questions about the moral permissibility of the applications of the resulting research itself, or evidence that the benefits of said research will be unfairly distributed. These are my millions of references, and thank you very much.